honor to really be presenting this year's Maude lecture on the wide spectrum of endocrine tumors. As I read about Maude, I was really impressed by all the things she did in terms of service to the Academy, as well as all of her contributions to pathology, especially studies of cardiac pathology. One of the culmination of many of her studies was this Atlas of Congenital Cardiac Disease, which she studied over 1,000 congenital heart cases and came up with this very outstanding atlas. Her contributions were so great that one biographer referred to her as the Madonna of the heart, a very catchy and very prominent title as such. I was sort of, in reading all about her contributions to pathology, I noted that she had not really engaged in studies of endocrine tumors, which is the topic of my talk. But as we'll see with one of the cases that I'll be presenting, there will be some overlap, and Dr. Abbott, if you were around today, would be very interested in some of the findings and spin-offs from this first case. Before I get into my talk, I'd like to mention some of my early influences that led me into pathology and some of the individuals along the way that really were inspirational in my continuing to study pathology. As a medical student, Dr. Reza Hafez, as well as Dr. Tom Warner, were really outstanding general diagnostic pathologists. And these individuals really inspired me to go into pathology, and then as a resident, they were very instrumental in teaching me many aspects of pathology. In addition, Dr. Henry Pito, who was a researcher as well as the director of the famous McCardle Laboratories for Cancer Research in Madison, Wisconsin, was another inspiration. He not only worked very arduously in his task in his research lab as well as administrator, but also was contributing to the service aspects of pathology by serving on the autopsy service on a regular basis all the years that I was a resident at University of Wisconsin in Madison. After I finished my training at University of Wisconsin, I was privileged to receive a position to do a fellowship at Memorial Sloan Kettering Cancer Center. And again, one was sort of overwhelmed by the giants in pathology that one interacted with and really signed out with on a daily basis at this institution. These individuals not only taught me about the science of pathology, but also about the art of pathology, and these two certainly are important for diagnostic pathology today. My first job was at the University of Michigan, and again, I met very outstanding individuals in pathology, ranging from Dr. Henry Appelman, and later on, when Dr. Weiss joined us, Dr. Sharon Weiss on the faculty, who were really great role models. In addition to many surgical pathologists, Dr. David Karen, who was a clinical pathologist and immunopathologist, was also a great role model, as was Dr. Bernard Naylor in cytopathology. After working in Michigan for some years, I went on to the Mayo Clinic, and again, was really inspired by the tremendous depth of talent of pathologists. These individuals, many of whom you recognize as outstanding pathologists in subspecialty areas, were also outstanding general surgical pathologists, and they performed a unique approach to surgical pathology that was used at the Mayo Clinic in terms of looking at sections, and most cases initially at the time of frozen section. There are a couple of other experiences that I just want to mention. One was, first of all, acknowledging all of my colleagues in endocrine pathology who have been inspirational over the years. This is especially true of Dr. Coleman Kovacs at the University of Toronto and St. Michael's Hospital, and the late Bert Scheitauer, both of whom worked with me for many years, and we produced many studies on pituitary tumors as well as other endocrine tumors for a long period of time. One of the joys of my career for the past 10 years has really been the editor-in-chief of Human Pathology. I've been privileged to interact with many talented members of as associate editors, as well as a really vast editorial board that one has of outstanding pathologists. And we also have a review panels of many, many pathologists, not only from the US and Canada, but from all around the world. And these individuals have really worked tirelessly in really promoting the quality of articles that are published in Human Pathology. And last but not least, I'd like to thank my wife, Debbie, who's really been a fantastic partner for the last almost 40 years in inspiring me and working together as we've done for those years. What I'll do is give you first a brief overview of endocrine cells and tumors, and then present 3 brief case studies, and then talk about new development in these 3 diagnostic areas as we move along. If one looks at the endocrine system, you can consider it from the perspective of being divided into 2 great areas. One, the diffuse or dispersed neuroendocrine system, which is the vast majority of these lesions and normal cells, and the other being this small group that I refer to as others. The others include lesions and normal cells of the adrenal cortex, steroid-producing cells, cells that are steroid-producing in the testis as well as the ovary in this group. And the vast majority of these others would be the thyroid follicular cells and lesions derived from these. As we know, thyroid tumors constitute about 1% of cancers that we see in surgical pathology, so it does encompass a large number of these lesions. The DNES, or diffuse neuroendocrine system, is really the larger group, and one has cells and then lesions such as mainly tumors derived from these that we're diagnosing on a daily basis in pathology. These would include C cells of the thyroid, cells of the adrenal medulla, neuroendocrine cells in the lung, and the skin, such as the Merkel cells and tumors from these, pituitary, GI tract, paraganglionic tissues distributed throughout the body, pancreatic islets, and parathyroid, as well as endocrine cells that are dispersed among organs that we do not normally think of as endocrine, such as the prostate and thymus and many others. One of the ironies of our subspecialization in pathology is that even though endocrine pathology is rather vast, we've really become more constricted because of subspecialization. For example, lesions of the adrenal medulla now looked on by or examined by the urologic pathologist. Neuroendocrine cells and tumors of the lung would be examined by the pulmonary pathologist. Skin tumors, of course, by the dermatopathologist. Pituitary by the neuropathologist. Paraganglionic tissue by the soft tissue pathologist. GI by the GI tract, and the pancreas by the GI pathologist, and even the head and neck lesions, thyroid and C cells by a head and neck pathologist. So the world of endocrine pathologists is shrinking in one way, even though as we become more subspecialized. So sometimes one feels like one of my favorite comedians, Rodney Dangerfield, who talked about getting no respect. But in general, we're thinking of endocrine pathology not only in terms of structure, but function, and these are usually integrated together. So the first case is that of a 55-year-old woman with a 3.5 centimeter adrenal mass. Workup showed slightly elevated cortisol and mildly elevated catecholamines. A needle biopsy of the adrenal was performed. And we were sitting around the table at QA conference, and this was the slide that was flashed across the screen with the multi-headed microscope. We see a lesion with relatively uniform cells, a little higher power of that, showing the cells have moderate amount of cytoplasm. And then when we go to the periphery of the lesion, we see that there's some cells with more eosinophilic cytoplasm here. And a little higher power shows that there's some cells with more abundant basophilic cytoplasm, looking more like an adrenal medullary lesion rather than the cortical lesion, which was the first impression from looking at the slide. We did stains for the lesion, and it was positive for chromogranin A, as can be seen here. The adrenal cortex, which is in this area, was negative for chromogranin A. So we know that it is a medullary lesion that we're looking at. It was negative for calretinin and MART1, but positive for synaptophysin. And as we know, both adrenal cortical and medullary lesions can be positive for synaptophysin, so that does not help that much in the differential diagnosis. The tumor was a pheochromocytoma, the small cell variant. I'll not be talking about pheochromocytoma in discussing this case, but talking about our development of a monoclonal antibody that detects neuroendocrine cells, pheochromocytomas, and others, that's used not only in the US and Canada, but all around the world by surgical and other diagnostic pathologists. And this was published first way back in 1983 in Science. I worked with my colleague, Barry Wilson. This was Barry Wilson back at that time in '82. We had both come to Michigan at around the same time. He had been doing a postdoctoral fellowship in San Diego, and I had come from Memorial Sloan Kettering at the time, had been working in surgical pathology, and was also learning as much as I could about cell cultures in the lab during my spare time. This is Barry back last year when we visited with the USCAP meeting in San Diego. He had abandoned the research part of his life and had gone into become an attorney and was a patent attorney at the time. We were rather idealistic during this time, and because hybridoma technology was very popular, the Nobel Prize had just been awarded a few years earlier for hybridoma technology to a couple of the recipients. We thought we could generate monoclonal antibodies, and that would help us solve so many problems in the world. For example, distinguishing benign and malignant endocrine tumors that are so difficult to diagnose and such. So I was on service at the time. A pheochromocytoma came into the lab, and we had gotten IRB permission. IRB, of course, was a lot easier to get in those days than it is today. So we had permission. We took a part of the tumor after the frozen section diagnosis was made, rushed it over to the lab, generated tissues that were injected into the mice to generate the antibodies. We screened a lot of antibodies, and this slide shows one of the first tumors that we had stained, which was a neuroendocrine tumor in the ovary that was positive for this chromogranin. One of the reasons we were so excited about this was that you can tell that this is paraffin section. And in those early days, those of you who were working with monoclonal antibodies in the early days know that many of the antibodies that were generated were really working mainly with frozen tissues as such. So it was a very powerful tool to have this tumor staining so diffusely. We did not know the target of this at the time, but worked that out later. Here's another example of the chromogranin A antibody LK2H10 staining adrenal medulla, but not the adrenal cortex, indicating a great degree of specificity. We also discovered in looking at these slides, using these ascites fluid from the mice, that this antibody was very powerful in other ways. One could actually stain individual cells. We had used Gremelius histochemical stain, Cherokee and Shank. Those of you that are older in the audience know about these, and sometimes they didn't work very well. But with monoclonal antibodies, and this particular one and another one we had, one could really outline